Hi, I'm Frank Diamond, the Managing Editor of Infection Control Today. We give infection preventionists and other healthcare workers on the front lines of infection control the information they need to battle COVID-19. Here's what is happening on May 1st, 2020. According to Johns Hopkins University, the number of confirmed cases of COVID-19 in the world, nearly 3.3 million. The number of people in the world who have died from COVID-19, over 233,000. In the United States, more than 1 million cases of COVID-19 have been reported, causing over 63,000 deaths. More states in these United States are talking about easing restrictions and getting back to normal. And so are more countries in the world. India, Malaysia, and Australia all want to ease their lockdowns. But COVID-19 has proven to be unpredictable, if nothing else. For instance, as CNN reports, Singapore saw an easing of cases. It recorded 528 cases yesterday, Thursday. That represented a slight easing of the COVID spike there. But then today, Singapore is recording 932 new cases, up again. In South Korea, a major milestone was reached Thursday. No new cases of COVID-19. That's the first time that's happened in 72 days. Then today, another new case. It's possible that this ebb and flow might be the new normal and that COVID-19 will be with us for a long time, or at least until they find a vaccine. It was reported this week that the federal government wants to turbocharge the efforts to get us a COVID-19 vaccine by the end of the year. In the world of vaccine approval, that's a blink of the eye. Data is coming at us from all sides, and because COVID-19 is so new and because the world is anxious to put this behind us, some of that information is flawed. Experts contradict each other. It's difficult to understand just what's going on. Dr. Kavanagh, a member of Infection Control Today's editorial advisory board, offers some tips about how best to separate what's useful information from what's not so useful information. My interview with Dr. Kavanagh is coming up next. For these and other stories, visit infectioncontroltoday.com. Hi, I'm Frank Diamond, the Managing Editor of Infection Control Today, and I'm here with my good friend, Dr. Kevin Kavanagh, who is a member of our editorial advisory board. Dr. Kavanagh has been looking at COVID-19 from the get-go, saw it as a danger, and one of the dangers that he sees and has written about and talked about is flawed data. He wrote for us about hydroxychloroquine and how that's been touted as a possible cure for COVID-19. So Dr. Kavanagh, let's talk about this. We'll start with hydroxychloroquine. But in general, the data that's been coming out about COVID-19 and infection preventionists and other healthcare workers, they have to be careful about this, what they read, right?
Yes, they have to be extremely careful. Everything is sped up, and the normal checks and balances, which were not that great to begin with, have been loosened. Most of the studies are going up on MedRx, not peer-reviewed. They're taken, putting into decision-making on what to do. There are many of these studies which are conflicting, some which have severe flaws. Almost all are retrospective, which means you're not looking at randomized control groups. They can be extremely biased. And the researchers also can be extremely biased. You know, we've talked about many times before the biases that are created by finances and associations with pharmaceutical companies. Well, now you have huge desires and biases to desperately find something that works because you're seeing thousands of patients that have succumbed to this disease. Some doctors are literally having breakdowns because of the severe nature of this epidemic. And so they have an intense desire, just like patients, to grasp at something that'll work. And it's not necessarily will be something that actually works. And sometimes it could cause more harm than good. So while we want to make sure that patients have every chance they possibly can have to do well, we also don't want to have them being exposed to a drug or a cure which may cause harm. And that's one of the problems we have. And of course, that was what was in question with the hydroxychloroquine debacle. Hydroxychloroquine was first touted, I believe it was from Chinese officials through President Trump. He explicitly said he wasn't a doctor. I'm sorry about that. And he, was very hopeful that this would be a cure. However, a number of studies after that seemed to show that it wasn't. And indeed, study after study now, with the exception of a very first one, have shown that they haven't been able to see an effect. The first study was, again, I think it was kind of biased. It did show a positive effect, but after it was reviewed and the research methodology looked at, a warning was placed on it by the journal and the sponsoring society of the journal. And that's, I think, created really a lot of problems because people went down the wrong path. Many people were using hydroxychloroquine, sometimes on an outpatient basis. Individuals that needed it, such as those with lupus and rheumatoid arthritis, were then not able to get the drug, and this caused harm. And a number of these individuals, up to 8% in trials with normal dosages, were getting QT interval abnormalities. In higher doses, there were even some patients that had atrial fibrillation. So this was a drug that had a lot of harm that could occur and very little benefit from what we're seeing in a number of trials that have come afterwards. Now, all the trials which came afterwards, of course, are relatively small. They're not necessarily well controlled, but when you get study after study after study after study that are not finding something beneficial, you have to start taking a look at that and saying, well, there may be something here, because all of the biases and all of the problems related to these studies should equally bias the study towards doing well versus not doing well. And that's what I'm talking about, is biases of randomization. Mm. And so when many studies that come after that are negative, then probably we've got a problem with this drug. And so certainly I would not use this drug outside a clinical trial. And this is something which is still, I think, being used by consumers on the outside, and this has caused harm. Another issue has to do with ACE inhibitors, where there's one study which was done in the VA which shows that they may cause harm. Another Chinese study says they don't do any difference between causing harm versus being beneficial. And a third Chinese study, which in my opinion, the results are almost too good to be true, showed that they may actually benefit the patient with a 2.6 times better survival. And I think that study's raised some eyebrows because of the results are just too good to be true. And then you counteract that with the VA study, which shows that, well, there may be some harm here. And a lot of these studies I don't think are well controlled. So this is also up in the air. So when you try to make clinical decisions on data that you're generating and publishing in the time period of weeks, as opposed to many months and years, and all of which tends to be unconfirmed, it's very difficult to make clinical judgments. And that's one of the reasons why you've got to keep an open mind, be very careful of the data that you're getting, and remember that people that are giving you advice are really not giving you expert advice based on good data, because it's just not there. They're giving you their best guess. And so it's best to look at the data and try to make up your own decisions on whether or not you should go down that path. And of course, informing the patient is extremely important. Informed consent and having the patient making the decision and participate with the decision is really one of the things that needs to be done in this epidemic, especially because our data and our clinical guidance is so unsure at this point.
How much is this a function of COVID-19 being so new, and how much, and we're dealing with the unknown in a lot of ways?
Well, I think that definitely is a factor. We're presented with a pathogen that is brand new, that we don't have much experience with. We really do not know how this is going to play out. Now, we have had coronavirus infections before, such as MERS and SARS, which gives you some guidance, but this is really much more contagious. And in that sense, on a societal level, it's much more deadly. Because the more it spreads, the more people that can become infected and then are set up for having either disabilities or death, which is creating tremendous havoc on our society. The other thing that's happened is because of its infectious nature, this epidemic has progressed extremely rapidly to where you've gotten into emergent situations in the matter of weeks where the healthcare system is being overrun. And this is causing people to really become frantic and to make decisions on the data that's there. It's not even good data, it's just best data that's available. And so a lot of the decisions that we're currently making in guidance, I think will be revised and improved as the weeks go on. And that's one of the reasons why I feel that the strategy of social distancing is so important, because as we buy time with this epidemic, we not only get our healthcare system up to par, but we also start to shed a light on what's good data and what's bad data and what our guidance should be going forward. And so buying time during this epidemic is extremely important.
Our magazine, as you know, you're on the editorial advisory board. We go out to infection preventionists, hospital administrators, environmental services people, procurement people, sterile disinfection professionals. Now they're all sifting through data too. So is there any general rule of thumb you can give them as they're looking at the data and looking at the information that's pouring in?
Well, when you look at the data, you need to look at the type of study that was done, whether it's retrospective or prospective. You have to look at the level of significance that's been obtained, and you have to look at the level of significance in relationship to the type of question being asked. For example, if something is going to be touted as a benefit, you would usually want to have this a very high level of significance. On the other hand, if you have someone who is dying and you have a whole ward filled of those people, then you may be willing to try something that might work or give someone a chance when you're not really sure. And of course, here you need to have experimental protocols, ethic boards, informed consent. And all of that is extremely important. Now, when you get into the question of causing harm, I don't think you need to have as a high a P level or a high level of significance. If you have an 80% chance that this might cause harm, I would take note of that. I wouldn't say, well, it didn't reach the 95th percentile gold standard, so we don't need to worry about it. No, if there's something 80% might cause harm, even 50% might cause harm, that's a red flag, and that needs to be noted. And then you also need to look at the institution, the experience of the researcher, and by far, look at the methodology of the study. There are a lot of studies we have seen where the results look good, the data analysis looks good, but the methodology just isn't there. For example, on the one ACE inhibitor study, which was touting its benefit in lab animals, when we looked at it, the exposure of the animal to the drug was just either not specified or was in a few hours, less than 4 hours, which probably wasn't enough to get upregulation. And so that's red flags. Now, of course, a normal clinician can't necessarily do that, but there's a lot of these studies that you can make a deep dive on the methodology to make sure that the study was conducted in a way that it wasn't either set up to fail or set up to succeed. And that's extremely important. The initial hydroxychloroquine article had some questions in methodology on exclusion and inclusion of people who were in the study. It was actually exclusion that I think had more of a question regarding. And so looking at the methodology is also important. Normally, you don't have to do this. It goes through a journal review. You have comments and letters, competing articles that come up, but that's not what's happening now. These articles are going up on MedIV, and you just have to get there and read the article, read everything, not just the abstract. And so that's, I guess, one of the keys.
Okay. Dr. Kevin Kavanagh, thank you so much for being with us again today, and stay safe.
Okay, same to you, Frank. Thank you very much.